the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Today's podcast is on common fractures of the foot, and I'd like to welcome Dr. Nick Viens to our podcast. Welcome, Doctor.
Hi, thanks for having me.
Yeah, absolutely. So just a brief background, it's pretty easy. You did everything at Duke.
I did, except for fellowship. I did go away for that. I went to Vail, Colorado, and worked there at the Stedman Clinic.
Right. Fellowship trained in foot and ankle. What led you to orthopedics?
I really liked how it focused really on trying to make people's quality of life better, and patients really felt like you did something for them. Typically,
Hmm.
you help them with their broken leg, or you helped them deal with the fact that their knee or their hip or their foot just didn't work like it used to, and they couldn't do the things they used to be able to do, and you help kind of get them back to those things. Like the variety of it too, and definitely liked the surgical aspect. So
Okay, awesome.
although most of what I do is non-surgical, really, if you compare.
I know. Well, today I was hoping we could talk about common fractures of the foot, and I realized there are, we could do a podcast on just one specific fracture.
Sure.
So we're going to cover a lot of ground. But I would like to just get some basic information on different foot fractures for our listeners and help them maybe develop a more accurate differential diagnosis. Um, so,
Perfect.
so yeah, I was thinking about if we broke it down into areas or zones, if you will, hindfoot, midfoot, and forefoot. From a bony standpoint, if we started at the back, I think calcaneus and talus. Is
Yep.
that what you would say? What
Agree.
what kind of mechanism of injury would someone have to have a fracture of the calcaneus or the talus?
Oftentimes it'll be a like axial load, so falling from a height, or stepping in a hole at some with some sort of force. Um, Although a twisting mechanism definitely can cause a fracture of the talus or the calcaneus, although it tends to be a little different type of fracture than what people are typically thinking of, which is one of the important reasons to really have podcasts like this. Because if you don't know to look for it, you won't ever see it. So, um, you know, one of the common um, sort of missed fractures that can happen, at least alongside an ankle sprain, or be misdiagnosed as an ankle sprain, are these fractures of the talus and the calcaneus, specifically, for example, the lateral process of the talus or the anterior process of the calcaneus. Um, can happen, and people can present as an ankle sprain, the twisting injury, and they had pain, and they may or may not have quote negative X-rays, um, and they actually have a fracture. But again, that can happen with an ankle sprain, so with a ligament tear, and you can have a fracture. And it's important to know to look for it. And even if you don't see it on X-ray, or the radiology report comes back and says it's not there, it doesn't really mean it's not there. Often you only can see these with an MRI or possibly a CT, which I'm sure we'll probably end up talking about later.
Right, absolutely. And, so I don't really want to call these red herrings because I know they do happen fairly often, but would you expect anything different on the physical exam, say with the anterior process, calcaneus fracture or the lateral process of the talus?
Yeah, oh, and they might just hurt a little bit, so they don't just hurt on the anterolateral ankle ligaments. They hurt more on the bone, which sounds obvious, but sometimes people just push on the ankle ligaments, or just take someone's word for it and says, well, it hurts in my ankle, and it's like, well, where in the ankle? And the biggest thing with foot and ankle exam is often just really pinpointing where exactly it hurts. And it's as simple as just palpating. You just kind of go slowly and just know your anatomy, and it's not that big of a space to have to know it. And it's a fairly all peripheral, so you can feel a lot of things if you just push around even on your own foot. So, if they hurt a little more anterior, a little more distal into the foot, and hurt on the calcaneus, often again on yourself, you can feel a little prominence there. Or if they're hurting a little bit lower down on the bone, um, the talus. Another fracture that can happen of the talus that we didn't mention yet would be like an osteochondral fracture of the talus, meaning they broke the joint. So
Hmm.
there's no such thing as an avulsion fracture from the talar dome. I've had that sent to me a couple times from outside urgent cares, and they're like, "Oh, there's a little avulsion there because you can see a little fleck of bone on the AP view or a mortise view of the ankle." And it's like, no, that there's no ligaments that attach to the joint surface, right, of the talus. So that means they broke the joint, they broke the cartilage, and that's something you want to deal with sooner than later too, because that means it'd be a loose fragment, or often those pieces are a lot bigger than you think.
Hmm.
So if you see a big chunk of bone off the joint surface, I mean, that's more of an urgent thing. It's certainly not emergent, but something you want to get seen. And that being said, no, that's different from a little avulsion from like the talar head, sort of near the navicular, that you'd see on a lateral view. And again, same kind of mechanism, either axial load, a twisting mechanism, or sometimes in those it's a hyperplanar flexion injury, and it sort of pops off part of the capsule from that
Hmm.
dorsal talus. And those are pretty benign injuries, and you might put somebody into a boot for a couple weeks until they feel better, but that's a whole lot different than a quote talar neck fracture, or even a lateral process or anterior process of the calcaneus fracture, which you might want to be a little more aggressive about just because they can go on to be a chronic source of pain for patients.
I have seen those anterior capsular avulsion fractures before, and people, primary care, get excited about it and send them over. But
Right.
yeah,
Yeah,
so
those are pretty unremarkable things. Every once in a while, I have seen once or twice out of the, I don't even know how many I've seen of those Taylor avulsions, probably 100 or more. Where somebody really knocks off a decent chunk.
hmm.
And that's different. That's a different ball game. Where if you really are getting into the joint surface and you pop up the dorsal part of the talar head off, yes, technically it's probably a bit of an avulsion, but that's again a different thing, and that should get dealt with. Same thing with the navicular. Well, it's right there. I know I'm skipping ahead a little bit, but it's the same joint. Those naviculars can have an avulsion off of them, and that's not a big deal. But if you're talking about really more into the joint surface, and the substance of the joint, that's again a different animal.
Are there any special X-ray projections other than the weight-bearing X-rays that you do for affected structures? And the other part of that is, MRI, CT, or does it just depend on what you're looking for?
Yeah. So the answer to that is yes. I mean, there's definitely special views. Mm, As far as the general orthopedist or urgent care setting, I wouldn't really stress about that, honestly, too much.
Hmm.
You can get Harris heel views, or there's various views of the talus, which I won't even get into really, because I think most radiology techs aren't going to know how to take it right anyway.
Hmm.
And if somebody really needs that view, they probably need to get in to see an orthopedic foot and ankle person anyway.
Okay.
People are probably more like bang for your buck and recognizing something isn't right, and then in getting the special views of the talus, looking at a talus, talar body fracture or something like that. A lot of those views are really best used anyway in the OR for doing reductions and checking reductions of the subtalar joint and things like that. But again, often these patients, you you're going to need advanced imaging. So if you have an obvious fracture that that you're worried about, there may be additional fractures, or you're thinking that this is definitely going to need surgery, or just you can tell there's something not right. Often, CT scan will be helpful for when you're making the referral. to the foot and ankle, or whoever you're sending it to, orthopedic doctor. Um, Now, on the other side of that, and this is sort of general orthopedic principles. It applies in the hand. I know, or really probably a lot of the joints is if you know there's a break, then a CT is often the way you're going to want to go. If you're worried that there might be a break, that you just can't see, an MRI can help a lot with that. So if you end up with a CT scan that shows no displaced fractures, well, there still could be a break, and you just can't see it on the CT. So then you end up with the MRI anyway.
Hmm.
But sometimes, you end up needing both, and that is not because you order the wrong study. It's that they give different information. But just a general rule of thumb: if you don't know there's a break, get the MRI. If you know for sure there's a break and you're trying to see how comminuted is it, or how where does it exactly extend to, like for a calcaneus fracture, for example, then
Right. Talking about surgery, and you've gone over some of this. Are there some general rules of thumb that we could think about or keep in our wheelhouse when we're seeing these folks?
tailor body, tailor neck fractures. I mean, those often, again, those are more high energy kind of injuries, but they often end up with surgery. Calcaneal fractures that are, even if they're comminuted but not significantly displaced on a CT, they might be able to be treated very well without surgery. Whereas somebody has depression of the joint surface, and those things, those are more likely going to get surgery. That's often what you're thinking about is, what does the joint look like? What does the alignment look like? Is the joint, is it all messed up and it's comminuted but it's lined up well? Then maybe you don't fix it, even though the X-ray looks nasty. You have to think, what are you going to be able to do with surgery? You can't undo the fact that they've injured the joint, so their risk of arthritis, post-traumatic arthritis in that joint is there, even if you do fix it perfectly, which, if
Hmm.
it's very common, you're not going to be able to do. So with some of those, if the foot's aligned well, you might just see how the patient does, and treat it non-operatively, and go in later and potentially do something, like often be like a fusion in the midfoot. So it really just depends, and that's where a lot of the subtleties come
Hmm.
in. Those are sort of the general ways of thinking about it. Same thing, lateral process of the talus. You can have a little avulsion, and it's not a big deal. But if you think about the lateral process of the talus, if it's a decent sized piece, that's really a intra-articular injury into the subtalar joint, and that might need to get fixed with a screw or screws. Sometimes even using like arthroscopic assisted treatment to stabilize the thing. And again, those are injuries that people can walk on it. People can just feel like it wasn't that big of a deal, and then they come and see someone like me 6 months later, and lo and behold, they've had a break all along that nobody ever caught, and they were told, "Oh, it's quote just a sprain," but really it wasn't, that at all. Or yeah, they had an ankle sprain or they injured their ankle ligaments, but they actually had a lateral process of the talus fracture, and now it's gone on to a non-union, whereas it might have been a lot easier to deal with it earlier. So
Hmm.
first, another thing to try to avoid saying is, "Oh, it's just an ankle sprain." An ankle sprain is a significant injury, even if it is an isolated ligament injury. And I know it's sort of off topic, but definitely something that's related to these foot fractures, and the same mechanism. So you want to caution yourself against just saying, "Oh, it'll be fine, no big deal." A huge part of my practice now is dealing with primary and recurrent ankle sprains, or these little fractures that we've been talking about. A lot of morbidity can come from that.
Hmm. This is all great stuff, and I know you're running short in clinic, and I really appreciate you taking the time. But do you have a case study or something you might share, or just something like the ankle sprains, like things that you see that people miss all the time, and what to look for?
I actually saw somebody last week. Somebody sprained their ankle and 6 months ago, and there's just sort of still hurting, and they were told at the urgent care, the emergency department, that nothing was broken, and here's a couple exercises, you'll be okay. And they've been doing exercise at home for 6 months and trying to get it better, and it just keeps swelling and aching, and now they start to have clicking and feels like it's going to give out. And they have the osteochondral not even just an osteochondral lesion, but a fracture that
Hmm.
just nobody saw on their X-ray, and now it's old, and we're talking about fixing it, or trying to fix it because the patient's pretty young. But um, again, those are the reasons. If somebody has a pretty bad injury, even if it's not, getting somebody follow up or just giving them the option. So if something doesn't feel right, or you start having clicking, popping, increasing swelling, feeling like it's giving out, you should definitely get in and see somebody. Because a lot of times patients are just made to feel like, well, it's fine. They told me it was just a sprain, and they feel like they don't want to bother people. They don't want to bother the provider. Everything's quote okay, but it's not necessarily okay. And I can't tell you how many times I have negative X-ray reports, so to speak, that aren't negative at all. I mean, you can see the injury on even the initial X-ray, and it's not the radiologist's fault. It's they don't have the patient sitting right there with them, and it's different. I mean, these things are subtle, and kind of you don't. It might see you, but you don't see it, and you definitely won't see it if you don't know to look for it. So you don't have to remember every one of these little fractures, but I think you do need to remember that they exist, and that if something just doesn't seem right, getting more information, or at least getting the patient to the right provider who does this all the time is really critical.
Right. That's really important. And gosh, this is so great. I'm really enjoying this. As a parting thought, do you have any recommendations for further reading or online resources where our listeners might do some more research or further study?
Yeah, the American Orthopedic Foot and Ankle Society has a really good patient education site. It's called footcaremd.com, which is really good, even for providers. There's some good resource links and exercises, little videos. The Orthopedic Academy, the AAOS journal, they had a really good review article about these little process fractures on the foot and showing some pictures of them, which I think that's a good one.
Hmm. Okay. Well, Dr. Viens, I really appreciate your time being on the OrthoPAC podcast.
Absolutely.
Great information. I know our listeners are going to enjoy this, and thank you so much for your time.
Of course. Thanks, Sam.
Thank you for joining the OrthoPAC podcast. Please visit paos.org, where members can purchase virtual CME content. This is accessed by clicking on the CME tab on the title bar, following the drop-down, which is the Learning Center. For non-members, please visit the aapa.org website for PAOS virtual content.
Hey, this is Sam Dyer, the host of the OrthoPAC podcast. I want to give a shout out to all of our listeners. You guys are rocking it for us so far. We have over 1,100 listens in just 2 weeks. It's just amazing. We couldn't do this without you. Keep listening, and if you like what we're doing, please subscribe and tell others about us.